So a couple of things. Do you guys know, do we show you these different sites where we tend to put a lot of this information? So this is a Dissect Facebook site, and your picture's already up there, but we'll get it mounted and send it to you. So it's just called Dissect, and that's what Dissect stands for. And it's run by our education group, and so it lets you know about all the new things that are kind of going on. This was actually finished in school last week. Yeah, this is the public outreach thing that we're doing. It's called Save a Life. So that's, if you're interested in seeing the other things that you can potentially participate in, and then it links up to this YouTube channel, and we put a lot of the content. So we have grand rounds lectures, but it's not just vascular that's in there. There's some vascular. The things that may be of value to you is boot camp we run in August, and all the lectures for the vascular lectures from boot camp basically are up there. And these are 15-minute lectures that are on the basics of vascular disease. They're not like, you know, how do you actually do complex thoracoabdominal aneurysm repair, but it's more an introduction really to it. Let's see what Yvette wants. Hey Yvette, I'm up here. Oh, I'm there. Yeah. Hello. I'm here. Making sure I turn up. Don't sleep in. So you guys are welcome to use these. These are open. They're not password protected. So this is actually from John I. It was one of the early boot camp lectures.
What do we do?
Well, I have got.
Okay. The amputations. There's a concern about the sort of psychiatric effect, the sort of post-traumatic stress syndrome for the surgeon and for the patient. I'll tell you that of all the operations we do, amputation is probably the one that's the most therapeutically effective. It's the one that patients oftentimes are more satisfied after than everything else we do. I had dinner with a guy one time that I actually knew pretty well, and had an amputation after, had an intervention, a failed intervention, a bypass, and eventually came to an amputation. And he said, that if he had known how good an amputation would be, he would not have gone through all the other stuff. And I actually think it's not, I'm sort of saying that facetiously, but I think there is some truth to that. He said even if he was sitting in a duck blind, he never had to worry about his foot going cold when it was fiberglass. And he could live and function. He didn't have to worry when he was traveling that when he got to the airport in London that his foot was going to go bad, and then he had to rush off to some hospital for limb salvage. Amputation is not a failed operation. It's a very successful operation with a very good outcome. So I think this image of the Grim Reaper somehow that both it's a failure for the patient and a failure for the surgeon is probably not true. There's a lot of amputees in the United States. Most of them have amputations as a result of vascular disease. The smaller number obviously for trauma and for tumors. The risk factors for amputation are mostly people who have tissue loss, end-stage renal disease, poor functional status, and diabetes are more likely to have an amputation. We need to talk a little bit about diabetes because they have a 10-fold increased risk for lower extremity amputation compared to non-diabetics. Amputees with diabetes are, and I've seen these very four topics on a question on a board exam. Amputees with diabetes are more likely to be severely disabled, to experience their initial amputation at a younger age, to progress to higher level amputations, and die at a younger age compared with patients without diabetes. Of all disc vascular amputations, lower limb amputations account for about 97%, and that's not too surprising. And about 50-50 are what I would call major amputations, that is BKAs and AKAs. What does the workup amount to? There's not a lot of workup to do with amputation patients. You obviously want to find out about their diabetic history, their renal situation, history of prior revascularization. I actually think that's fairly important because the likelihood that there may be some old residual synthetic graft in that limb is important because of its potential to predict eventual wound problems and wound infections. Myocardial infarction is the most common cause of death following lower extremity amputation. Pulmonary complications, including atelectasis and pneumonia, complicate about 5% of major lower extremity amputations. And the incidence of new onset renal failure after a lower extremity amputation is in that 1 to 2 to 3% range. And renal failure is associated with increased operative risk and long-term mortality. I think those are some sort of things to remember. The level of amputation is dictated we sort of think of it as these more of a technical issue, but really these are the principles that govern the level of amputation. That is the extent of the disease, the healing potential of the stump site, the amputation site, and the rehabilitation potential, the potential of the patient. The real reason to do an amputation is typically, we would say, if you've got pain that you can't control, if you have a situation where the limb itself is harming the patient, meaning, for instance, sepsis, or where you're releasing myoglobin, so you've got renal failure as a result of an ischemic limb, or you have interference with rehabilitation potential. That is, there are some people that will hold on to a wound foot too long, and they wind up harming themselves by hanging on to a dysvascular limb or a wound, where they would be better off if they went to a major amputation and continue with their rehabilitation. So I think those are the three reasons I sort of tell our people, why do you do an amputation? The presence of none of the three things there said that a gangrenous foot was an indication for an amputation. So you may well have people from a nursing home or otherwise not able to get around. They don't know really exactly what's going on. They've got a gangrenous foot. If it's not causing sepsis, if there's not pain, and if it's not preventing them from rehabilitating, you don't necessarily have to do an amputation. Sometimes we get shoehorned into that by our colleagues who will send somebody in from the nursing home and say, well, he's got to have an amputation, put you in a position to do an operation with a high mortality, and it's not actually going to help the patient. Sometimes Silvadene and a dressing that makes the appearance look better may in fact be an appropriate treatment for a gangrenous foot that's not otherwise a problem. And although preservation of limb length is desirable, it is essential to remove all non-viable and infected tissue. So now how do you figure out what level to do an amputation if you are faced with a ischemic leg? Basically, really, vascular surgeons use clinical judgment. The determination of amputation level by means of physical exam and clinical judgment alone is pretty good. 80 or 90% of BKAs will heal just on that alone, and 90 or 95% probably of AKAs will heal based on that. The presence of a palpable pulse proximal to the level of amputation is associated with nearly 100% success rate. Now you can do other things. You can look at Doppler signals, and you can do transcutaneous oxygen. You can look at the nuclear perfusion scans. The reality is that the sensitivity of these tests is not really any better than good clinical judgment in the hands of people who've done this before. So I'm not going to totally discourage their use, but the simplest test that really is useful is a Doppler signal at the popliteal. If you have a Doppler signal audible at the popliteal space, you're very likely to heal a BKA. Other than that, I don't find most non-invasive testing particularly helpful in determining amputation level. Now you can do these things. Obviously, if you have a pretty good ABI, your chance of healing is better than if you don't. If your toe pressures are reasonably preserved, you got a better chance of healing than if it's not. And if you have transcutaneous oxygen, the numbers there tend to be around 40. If it's greater than 40, it's not so much. If it's greater than 40, you have a pretty good chance of healing. Less than 30, much less likely to. A couple of other issues are infections. How you deal with infections in people with anticipated amputation, it's a little bit tricky. I've got one partner who does guillotine amputation virtually for anybody with an elevated white count and a fever who has a foot amputation. I tend not to do that, and I put them on antibiotics, and I tend not to close the skin very tight. But it's something to sort of, you have to kind of at least have a plan for. They virtually all should get skin-appropriate antibiotics, which is basically either Ancef or Bank, depending on their allergy status. DVT prophylaxis is something to remember in that it's one of the vascular patients. Amputees are the group that's the most likely to get major deep vein thrombosis, particularly in the limb that you've amputated, but also in the non-amputated limb, partly because of the bed rest issue. And because you have obviously limited flow back through the deep venous system on the side where you do the amputation. And nutritional status, although it's usually not possible to correct somebody's nutritional status, but people who have albumins, as the VA showed a few years ago, less than 3.5, are more likely to have wound problems and problems outside the limb in these amputations. What's the role of angiography in assessment of amputation level? basically the yellow line at the bottom, I think, is the main thing. It really, the angiogram as a whole does not really provide information about healing potential. You can see the big arteries. You can't see the small ones well enough to really predict anything. You can see these arteriograms to the left. It really doesn't tell you enough to make a decision. I was going to just mention just briefly Chris Attinger, who was a resident with 30 years ago, came up with this concept, or has really popularized it, I think, of the angiosome. And it really basically, you can see the posterior tibial artery, and the angiosome is sort of essentially on the back of the leg and the back of the heel. The anterior tib sort of fills the anterior compartment in the front half of the foot. The perineal tends to sort of fill down the middle, has a lot of overlap, obviously, with both AT and PT. But it's the concept is that you can have regional malperfusion in the foot, such that even though you revascularize and have a pulse at the ankle, you may still have failed revascularization in some certain situations where you still wind up with an amputation and a functional graft. What are the kinds of amputations? Basically, I just thought I'd run through these just so everybody knows what these are, because you'll hear about them at different times. There's a toe amputation, ray amputation, transmet, midfoot amputations, Lisfranc and Chopart, Symes, BKA. I didn't put through knee. It's not a very common amputation, AKA, and hip disarticulation. You can see this diagram of the foot. Basically, the Chopart and the Lisfranc are these sort of midfoot amputations that come back at the base of the metatarsals or through the tarsal bones themselves, intertarsal amputation. A toe amputation basically means you take off one or more of the toe bones themselves, but you don't touch the metatarsal head. A ray means you take the metatarsal head with the amputation of the toe. Most diabetic toe amputations will wind up being ray amputations.
So this stuff you need to know. We were at our conference a couple of weeks ago and asked one of our interns how to do a toe amputation, and he hadn't a clue how to do it. And so these are things you need to be aware of, because these are the sort of things you're going to be allowed to do. So you either take a toe off, you just make a ring incision around the toe, or if you've got to take the metatarsal head, that's where you make a ray amputation. It's kind of like a tennis racket incision. If this is one of my toes, you make an incision that comes along the dorsum of the metatarsal, round here, then comes back. You take this down on the metatarsal and you cut it off. So one of the things you can do and actually this wasn't even part of the course, but we could probably do some toe amputations back there today, because they're the kind of things that if you can do them, they're going to tell you just go ahead and take care of it.
Often you got osteomyelitis in the metatarsal head.
That's a bloody great idea.
Ray amputation again means the metatarsal head goes with the toe. Transmet, I've gotten more and more aggressive about doing transmetatarsal amputations, particularly in diabetics, rather than doing the sort of toe picking where you sort of get a 1 and a 3 and then a 4 and then a 5, and you sort of work your way across the foot. I found that my level of enthusiasm for that series of amputations is lower. I've become more convinced that really one good transmetatarsal amputation is better than preservation of really a deformed foot. The problem is in the diabetics is once you get particularly like a first metatarsal head, once you've taken the first metatarsal head, you so change the biomechanics of the foot that you start distributing forces so irregularly against the other metatarsal heads that you wind up with deterioration downstream. And a good transmetatarsal amputation can be quite durable and effective. Symes amputation you should have heard of. We don't do very many Symes amputation because you don't wind up with a full-length limb. As soon as you take the calcaneus, you've lost the foot. So the most proximal full-length amputations are the Lisfranc and the Chopart, which actually can work fairly well. I will say one of the things that you should keep in the back of your head on all of the forefoot amputations, particularly the transmets and the Lisfrancs and Choparts, is to cut the Achilles tendon. The problem with almost all those short foot amputations are that if you keep your lever effect of the Achilles tendon, you tend to wind up with recurrent ulcerations on the front half of the foot from sort of the equinus deformity that occurs. And we can do, you can transect, and I transect the Achilles tendon on virtually all transmets with just an 11 blade, just as you would do a lateral internal sphincterotomy, where you just take the blade, turn it toward the lumen, and transect the sphincter muscle. do the same thing on the back side of an Achilles tendon with an 11 blade. Take that tendon and free it, and now your foot comes up to 90 degrees. You don't have this tendency to push down and damage the front half of your amputation. SIMs are particularly problematic in diabetics because they're sort of just neuropathic. It's just not a very common operation. BKA is the sort of workhorse amputation for what we'd call a major amputation. We usually differentiate any kind of foot amputation where you maintain full length of the limb as a, quote, minor amputation. Major amputations are those where you shorten the limb. There's a bunch of different ways to do BKAs, the so-called posterior flap, which is really the most common one that most everybody does, skew flaps and sagittal flaps, and there's even some other sort of spiral flaps you can do. There's been some pretty good studies where the healing rate didn't correlate with the type of amputation flap that's done.
All we need to know about is the posterior flap.
So
And the big technical error is making it too short, so it doesn't. There's not enough room left. Always make them long.
I only put this up there to remind you that there are some nerves. The sural nerve sits on the back of the BKA stump. The saphenous nerve runs down the medial side. The sural nerve, I think, is more prone to development neuroma. We tend to try to cut those nerves back into subcutaneous tissue so they're not on the weight-bearing, or at least on the bottom surface of the amputation. Post-op pain is important. They can get because not all post-op pain is phantom pain. Some of it's due to ischemia, some of it's due to neuromas, some due to pressure points where there's little bone spurs that develop, some is due to infection, and some, of course, due to phantom limb. But it means that just because somebody comes in, they've got pain in their stump, you've got to stop, think, and try to differentiate what the cause is, because some of these are quite treatable. Complications, 34% incidence of perioperative 30-day complications in 3,000 BKAs. Return to the operating room in 15% of amputations in NISQIP. History of sepsis, alcoholism, steroids, cardiac disease, renal insufficiency, and prior infections are independent predictors of these complications. Most patients won't walk with prosthesis, and they don't not because of the prosthetic problem, it's because they don't generate enough cardiopulmonary output. It takes more energy to walk with a prosthesis. It's almost like walking on stilts. It's like jogging, and most of these people don't have the cardiopulmonary reserve. You can predict the people who won't likely walk. If they weren't walking pre-op, they're not likely to walk post-op. If they've had an above-knee amputation, much less chance. If they're old,
Let's tell them his time is up.
Long-term survival is quite short, 50% one-year survival for AKA. So it's not a good thing to have an amputation, but some of that I think is because we wait so late in the course of the disease. Thank you.
All right. So you'll,
Dr.
again,
Ed, thank you very much.
Again, the sort of things that you're going to get involved in are going to be toe amputations, ray amputations. You're not going to be asked to do a Symes amputation or a Chopart or Lisfranc. And you will get to do BKAs and AKAs. Did he cover AKAs? Was that mentioned there? Did we miss it out? All right, let me tell you about AKA. So there's some practical things for doing a BKA. And you know, the more stuff you give away off your service, the fewer faculty you have and the more call you got to take. So if you can get access in the OR, you're better off keeping all the stuff, you know, in-house. The more complex things we'll often give away to the orthopedist. But essentially what you do with a BKA is you take a tibial tuberosity and you go a hand's breadth below that and you make a horizontal incision. Then you go another hand's breadth at least and you make a posterior flap that's curved like that, okay? And then make it a little bit longer than you think it's going to be. You can always trim it off. There's nothing worse than you cut the bone and you're pulling up in that posterior flap and it's too tight because then it dehisces anteriorly. An AKA is made basically using a fish mouth incision. So again, everything's about a hand's breadth. Lord knows why that's the case. But you put a hand's breadth above the knee and you can make a mark. And what you do there is you make a fish mouth incision like that. And so it looks like the front of the fish. And then you trim the femur way back. Biggest mistake you're going to make there is not cutting the femur back far enough. And then you come back to the office, then your femur is sticking out the end of the amputation. That's not good. So those are the amputations that it's worthwhile you knowing something about. Let's talk to you a little bit about vascular. Who knows about vascular grafts? Different kinds of vascular grafts. Have you ever seen these things before? Yeah. Okay, that's good. You want to tell me about them? Well, tell me about the basic vascular grafts that are out there. That's always good since Jason's paying for this, so it's always good to start with that. That's smart. Okay. Yep.
And then there's also Dacron graft.
Okay.
Those are the synthetic grafts that I know.
White tube guys. These are the PTFE grafts. Okay. And this is Dacron. So we can pass these things around. You guys can look at them. I mean, honestly, that's basically it in terms of prosthetic grafts. You can modify them. So if you look at that PTFE graft, it's got external rings on it. These rings are designed to go across compression points. So if you run it for do an AXFEM, for example, and it crosses the iliac crest, the patient rolls over and sleeps on it. Probably doesn't completely prevent it being compressed, but it certainly helps. These rings are removable. Just grab them and kind of rip them off. And we'll talk a little bit about the composition of these things. So by and large, think about Dacron grafts as we replace big blood vessels with Dacron. You replace the smaller blood vessels with the PTF. Almost nobody uses Dacron below the groin. Inside the abdomen, you can kind of go either way. It doesn't really make any difference. Most people would probably use Dacron when they're replacing the aorta, either up in the chest, and descending thoracic, abdominal. Most of that is going to be Dacron. Reasons for that, part of it is just tradition. Part of it is fear of bleeding with the PTFE. The downside of PTFE is much less thrombogenic. So Dacron is very thrombogenic, which is kind of interesting. When I was a fellow at Emory, we used to work on thrombosis models. The thrombosis model was a piece of Dacron. We actually sewed it into an exteriorized baboon circuit. There was a big primate center at Emory, and they had shunts put in the femoral vein. It perfused through a piece of silicone, and in that you'd mount a target, and the target was 4mm Dacron. Always occludes in every time you do it. And so very rapidly you get platelet deposition, and it would go into occlusion, and it was used as a model for we'd infuse the new antiplatelet drugs upstream of it and see whether we could change the platelet deposition curve and the patency of these things. PTFE is not near as thrombogenic, so it's kind of remarkable that Dacron actually works as well as it does. But it is, the healing characteristics are completely different in terms of how these things heal. So bottom line is none of them endothelialize. Okay, so none of the artificial grafts that you put in ever have confluent endothelial growth from top to bottom. The Dacron is kind of largely lined by thrombus. The PTFE, it's interesting, PTFE is made of so-called nodes and fibrils. I'll show you examples of that. You can actually control the porosity of it pretty well. Before we go on to that, just let's mention, anytime you go below the knee, you want to use autogenous graft, if at all possible. Okay, so you look once, look twice, look 3 times for a piece of vein that you can actually put down on there. And we kind of do venous surveys, so we'll look at both the legs and we'll look at the arm. If need be, we'll splice a piece of vein together. That's now big question is always, when does multiple spliced veins worse than an artificial graft? And I don't know the answer to that. So it's saphenous vein before arm veins, because you got a pretty long piece of vein. If you come from here all the way here, you can get a nice long piece of vein. You can do a below knee bypass with it. The problem with arm veins is people stick needles in them all the time, and so there's much higher incidence of recanalization, thrombosis, scarring in arm veins than there are, in the lower extremity. And we survey all of these veins before we actually go take them out. So send them up to Vascular Lab, say, hey, vein survey. They'll look at both legs, both short saphenous and both arms, and tell us really what's available up there. And you can use them in reverse or non-reverse, doesn't really matter. Dacron, since you're in Houston, I've got to tell you the Dacron story, unless I've already told you the Dacron story. Dacron didn't exist until DeBakey went to Foley's department store downtown, doesn't currently exist. Was looking for Vignon N, which was kind of what was being used at that point in time. And the attendant said, well, we don't have any. But we've got this new stuff called Dacron. You want to have a look at it? Big old sheet. And he says, yeah, it looks pretty good. Give me that. Took it home, sewed it up into a tube in his wife's sewing machine. Said he applied to the IRB. That was him. So he asked himself, he said, yeah, and so he put it in the patient the next day. And to this day, Dacron is still the most commonly used replacement really for an aorta that's out there. One of the reasons it's kind of useful is because you can see it's stretchy and it's compliant. It doesn't kink very easily. And it comes in a variety of different configurations. For the visceral segment, you can get it with multiple different branches in it. And you do get ingrowth into the outside of this. We'll show you what it looks like under a microscope. Comes in different formats. Woven is a little bit stiffer than Dacron. Don't worry about this stuff. Knitted came along a little bit later. I think I just pictured. This is what woven is. This tighter weave. Used to be you had to pre-clot these things. You don't have to pre-clot woven. This is a looser weave. You did have to pre-clot knitted, which was always kind of exciting if you forgot to actually do it. And then you sewed it into a patient who's now fully anticoagulated, take the clamp off and just go, right through this. It was a bit of an issue. So most of these things are now impregnated with some sort of collagen impregnation to make them impermeable, so that if you forget to actually pre-clot them, the patient doesn't exsanguinate while you're sitting around there waiting for some sort of clotting to actually occur. So the woven is a little stiffer. Most people use Dacron. It doesn't really matter. It's more a matter of personal preference. Pre-clotting, gone. Too hazardous in order to do that. So first cases were all basically reported here. Doesn't really matter about this stuff. So that's kind of what they'll look at. Now, some of them are called so-called double velour. In other words, they have these external loops these are microscopic. You can't see them looking at them, but it supposedly helps the healing. I don't know if it makes that much difference. PTFE, you want to tell the PTFE story? Do you know it? Go ahead. Why don't you tell them the PTFE story? It's pretty interesting.
Well, I mean, the way I've heard it may be different than the way you've heard it. So, Mr. Gore and his son were both engineers and working in Delaware for DuPont. And Mr. Gore kind of started thinking there's got to be some other way you can work with Teflon. It's got to be something else. It could be something else. So he and his son were in the basement working, and we were trying to pull this tubing out of this little contraption, trying to make it work, and he thought it had to do with speed. So the slower he went, it just wasn't working. It was coming out in blobs, and my mom always told me nothing ever comes out of a bad temper, because I had a little bit of one.
Mm-hmm.
But now I can argue that, because the way I kind of figure is he just got really ticked off one day and was very frustrated. He got this tube and just pulled it, probably dropped the word, dang it, like that, and pulled it out, and it came out in this long tube. And he looked at it, it was like, it actually did matter how fast it was coming out, but it wasn't slow, it was how fast it came out. So that's how they started making PTFE, was him losing his temper a little bit. He took it to Mr. DuPont. Mr. DuPont said, we don't really have a need for that, good luck with that. And so literally in a basement in Delaware, that's where Gore started. And I was telling somebody who has John Hoover's in their territory. Jack Hoover was the first sales guy. And you can tell the story about the snow skiing. You know that one?
Huh.
Yeah, there were Jack Hoover and a surgeon were riding up they were snow skiing, and he started talking about what they started trying to sell and put it in a pig and just to see if it would work. And the doctor was like, well, I'll take some of those. And they basically put these tubes in a pig just to see if it would work. And the pig stayed alive for a little while, and they thought that was pretty cool. So it's kind of the same IRB that Gore used, or that Dr. DeBakey used. So they all of a sudden, Jack Hoover selling vascular grafts. Doctors, we don't even have a box made to deliver these things. So he started selling a bunch of vascular grafts, getting all these orders before we were even really making vascular grafts. So is that kind of what you're looking for?
Yeah. The anecdotes always help them remember it. And so you can vary the porosity. Typically it's said to be off-the-shelf stuff is in the 30 to 60 micron porosity. It's got these kind of nodes and fibrils. I'm never quite sure what the node is here, but I guess it's the node and these are the fibrils, and you can change that. And if you get it up to 90 microns, it wets out more, but it also then you get healing along the length of the graft. That doesn't seem to make that much difference. So when you sew these things in, you'll get endothelial ingrowth, probably 2 or 3 centimeters in either end of it. The rest of it doesn't endothelialize, at all. But these have been incredibly durable. Now again, above knee, works well. Below knee, anytime you cross the knee with any of these devices, you start losing 10 to 15% patency, over a 3 to 5 year period. And what's been done recently is that is to bond heparin onto the luminal surface of it, and it's bound in a way that it doesn't elute off, so it stays there for a long period of time, further decreases the thrombogenesis, and has been shown to increase the patency. Alexander Clues is probably a name, it's instrumental basically when I was doing research. I mean, he was a guy who was up at Seattle, and he was the one who worked on PTFE, variant the patency, and looking at neonal hyperplasia, and ingrowth. And it's been modified in a whole variety of different ways. People are worried about the hemodynamics of a distal anastomosis. They've expanded up the hood to try and see if they can maintain laminar flow. It doesn't seem to make that much difference. They've lined it with carbon to see if that would help improve patency. Doesn't seem to make that much difference. The propatin, or the heparin bonding, is the one thing that's actually been shown to actually improve patency. And the PTFE grafts are pretty almost ubiquitously used in dialysis access, upper arm, lower extremity bypass. We don't use it inside the abdomen. We tend to use Dacron. If there's a downside of PTFE, it's needle hole bleeding. Is that most of the time it doesn't happen. Every now and again it can go on for quite a while. So that's the one downside of it, and it doesn't. There's now it's made with a stretch format. So initially you had to cut it exactly right because it didn't stretch, and so making sure it had the appropriate length and making sure that it was across the joint that would flex across the joint was a little bit tricky. And now they've actually got stretch Gore-Tex, which kind of acts a little bit like Dacron in terms of its ability to accommodate these various different things. Ringed, as I say, we use it whenever, of course, we're crossing. Anytime we're worried about compression, we tend to use it. Grafts are tapered, for example. Dialysis access grafts tend to be, a lot of people just use straight 6 grafts. Some others use 4 to 7 taper. The idea is if you decrease the size of the arterial anastomosis, you can restrict the amount of flow and you're less likely to get steel. These things all come down to personal preference, what the surgeon's going to use. And then, the newer endos, because you've got heparin bonded in the inside, and now the whole PTFE construct has been switched over in the endograft. So this is really what many of the abdominal endografts are created from. And the Viabon, which is used for recanalizing lower extremities, basically looks like this. And then Jason's new baby, I guess, is the so-called hybrid graft. So, for example, this could be used. You can use it in a variety of different situations. It as a sutureless anastomosis, because you can deliver this up through a sheath, pull the string, the whole thing pops out. Then you've got the traditional component of the graft, which you can actually utilize. And so, where's the most experience with this? Is in what situation? Access?
We developed it for access.
No.
Because you basically have gone fistula, possible fistula, and then you've done a glute graft, and then you start running out of real estate. And the axillary vein is, like Dr. Peden says, it's in a bad place for a couple of reasons, because you're going through an armpit, which really stinks, and it's really deep in there on these dialysis patients with big arms. So we developed it thinking, get into the axillary vein with the sutureless anastomosis, you stick it inside the vessel, deploy it, done with that, and then you just tunnel down and sew it in to the arterial side. But we've done now, you can flip it any way you want to. And fin pops with it, done a lot of iliofemoral, so you go up with the stent, graft into iliac, and plug it in distally wherever you want to. The key to think about is, it is a stent, and it's a covered stent, so wherever you put it, you're blocking off any other flow, any other direction.
So it's an end-to-end anastomosis is what you're going to create. The other place you can utilize this is if you're doing thoracoabdominal aneurysm repair, and you're looking on the inside of the aorta, and you've got the superior mesenteric artery and 2 renal arteries. These things just take a long time. I mean, if each one of these anastomoses takes 15 to 20 minutes, you can pop this. If the renal artery here, you can pop it in there, deploy it, and sew it on the aorta. Move to the other renal, pop this in, deploy it, and sew it onto the aortic graft. So they've been used in a variety of different situations like that. The other thing you're going to come across are patches. So, for example, we did a femoral endarterectomy, we did a carotid endarterectomy the other day. All of those things, almost never are they closed primarily. If you make a transverse incision on the femoral artery, close it primarily. If you make a longitudinal incision, you just gather it up too much and you narrow it, so you always put a patch on there. And there's, again, there are a host of different kinds of patches that you can use. Like you can use PTFE, you can use Dacron. We tend to use this, what's called bovine pericardial patch. Recently we've been using core matrix, actually, which is just a different kind of thing. None of these things make any difference in terms of pain. So you just get one that you're used to and kind of use it over and over again. Any questions about this? Maybe you see the graft? Okay. So let me see. I'm going to show you some devices. Linda Lee's going to come up and talk to you about vascular access, but make a little space. Okay. Okay, what's this? First of all, look at the package, okay? It usually tells you everything that's on there. These things all hang up on a wall. And there's a myriad of different kinds of shapes of catheters. The common ones that you use are simple curved catheters, okay? Simple curve is one little angle on it. And I think Boston Scientific calls this an imager, a variety of different names for it. So what you're looking at is they come in a variety of different diameters. This one is going to be a 5 French catheter. I got a 5 French sheath in the groin. Does a 5 French catheter go through a 5 French sheath? Take a poll. No. 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 One yes. All right. Yes. Okay. Sheaths are measured according to their ID, internal diameter. Catheters are measured, so 5 French sheath will take a 5 French catheter, okay? 4 French sheath will not take a 5 French catheter. So that's important to know. Second thing it's going to tell you is what the length of this, and this is a 100 centimeter length. They come in different sizes. They come in 65 centimeters, 100 centimeters. Every now and again you got a 130 centimeter catheter. And the reason that's important is it depends what you're trying to do. If you're coming in the left groin, you're trying to get to the tip of the right foot, then you're going to need, probably 110, 120 centimeter catheter length. It's really infuriating when you spend a long time getting a wire down there and you don't have a catheter that will actually reach. So these are the kind of things you're going to think about, in advance. Open it. How do you open one of these things? Okay, you're the nurse, and you're going to hand that to the scrub tech. So what he's doing is doing it like that. Okay, that's good. And they're going to take this out, and it's going to come on the table. And it comes delivered like this, okay? What are they going to do with it for you? Okay, what are they going to flush it with? They're going to flush it with heparinized saline, okay? So they're going to have a bunch of stuff. Heparinized saline is going to be on the field. And these catheters, the way you control these, because this thing is going to be coming out through a sheath in the groin, okay? What you want to do, and you're going to have a wire coming out of here. The easiest, if you torque this thing from here, look, what's the end of this? It ain't going anywhere, okay? Because it binds on the valve. And as soon as you release it, the thing is going to start spinning. So by and large, you hold it at 2 points and you rotate it like this. And this is not wild rotation. You have control of this. Now, one of the reasons you may not get so-called one-to-one control is because this thing comes up through the iliac artery and then sometimes it's bent back on itself, and it doesn't quite control the way you want it to. But that's okay. That's just kind of the name of the game. Now, the reason that there's different colors at the end of these catheters is because they're made to be a little more radiopaque on the end of them, so you can see them, when you turn on the machine back there. Okay? So once you pass that around, because you're going to have a chance to play with these a little bit. So the diagnostic catheter, the name we use for a simple one is a Bernstein catheter. Okay, next, wires. Wires come in a variety of different formats. They come in the diameter of the wire. The workhorse wire and the big blood vessels is, anybody know what diameter the thing is? 035, okay, 035 wire. And wires are very important. The typical wires that we're going to use is, we use a thing called, let's see if we got any. As I say, each company gives these things a different name. Boston calls them a starter wire. We typically call them a Benson wire. Benson wire is the workhorse wire. It's the first one that's going to go up the aorta. It is a straight wire with a floppy tip, okay? These wires vary in stiffness. do not stick the stiff end of the wire in first. The nurse will hand you the wire. It's your problem if you jam the stiff end in, because you'll stick it straight through a blood vessel. And so all wires have a stiff end and a floppy end. They also come in different diameters. This is why I can't be a cardiologist. You can barely see this damn thing. And so they come in stiff end or floppy end. Pretty damn stiff, huh? Ooh, that's the stiff end of the wire. Okay, now watch the way you handle the wire. You take it like that, and you do this, okay? And that's the way you handle it. Otherwise, it's going to go all over the place. Now you feel that, you'll see a difference, okay? And so you want to you can handle the wire like this. Typically, they got a basin that's sitting there, and if you're going to hand this thing off and it's going to be flopping all over the place, you can fold it around itself a couple of times, and then you can actually throw it down, and you're not going to have this thing wanging all over the table. So this is a 014 wire, because it's so thin. This is like a corny wire. This is what you're going to use if you start going down on the tibials. And some of them are so-called shapeable, and that you can shape the end of it, you know, on a hemostat, so you get a little angle on it. Here's another wire, and you probably should pass these around together. Okay, first of all, Amy, know what this little thing is? Torquer, very good. So torque device is designed, so the packaging of this is pretty interesting. You know what this is? What comes with this? It's a cheater. It's designed to break the hemostasis valve to let you introduce the wire. So you got a valve sitting here, you jam that thing through it, you feed the wire in, and then you pull this back off the end of this thing. Now this is pull on this. It's not easy to pull it out. It's because this is like a glide wire. This one's called a Roadrunner. This is hydrophilic. When you wet it, it's really slippery. When it's dry, it's exactly the opposite, okay? You try to put a catheter over this thing, it ain't gonna go because it's so tacky. You gotta keep it wet. So I would say these things are your best friend, your worst enemy. Because once it's wet, and you're assisting me, if it's wet and I'm pulling on, I can pull it right out through your hands. You don't even know that this thing is moving. And so these are really good wires when you're crossing lesions, and it's got what's called good one-to-one torque on the end of it, so you got a lot of control over it. But when you're doing exchanges of catheters, it's a real challenge because you end up pulling out, lose all the good work that you've actually been doing. It's also the wire you jam through the kidney, okay? These glide wires are notorious that if you're working in a renal artery, typically we use this to get us there, then exchange it out for something that's got a little J on the end of it, so we're not going to jam it through the renal cortex. This thing, as you're doing wire exchanges, moves backwards and forwards and will go through the renal parenchyma. And these patients will sometimes present with bad problems because of that. So go ahead. Too hard for me. So you can lock this torque device. You lock the torque device onto the wire and it gives you a lot more control of it. So there's the cheater and the torque that you can actually pass around. And most of the information you need is on the front of these of the packaging. It's just a Benson wire. You can pass these things around too. Okay. Here's a sheath. Okay. The sheaths are all color coded. So when Linda comes up, you're going to impress her because you're going to know what all of these different color codes. So depending on the color on the back of it, we know exactly what size of sheath this is. So this is an 8 French sheath. Orange is a 7 French sheath. Green is a 6 French sheath. Now they come packaged like this for a very specific reason. People who don't know what they're doing, first thing they do is they take the dilator out. They package them like this so you flush them in one, okay? You hook up a flush, you flush it, you flush the sheath and the dilator at the same time, you take this thing out and you load it. And this locks in place. So that when you got a wire in the artery and you come to push this in and it backs this out, then look what happens. Now you're trying to jam this thing through the front of the artery. So as you introduce these need to stay together, and usually you got to hold them. If you got a big long sheath, you may need to have your partner who's actually holding the back end of this. And then you want to make sure that they turn the side port off. Otherwise you get it in, and it looks fine, you take this out, and you're standing there watching it, and you're getting wet, and it's because there's blood coming out all over it. So that's the sheath. So this is how you work inside an artery without exsanguinating the patient all at the same time. And Gore has probably got the best large bore problem is they made these things bigger and bigger and bigger. Those valves really could not hold the pressure, and so Gore has got an adjustable valve that is, almost everybody utilizes because it works so well, letting you put large bore devices, multiple devices in side by side going through the valve without the thing bleeding all over the place. Okay, we talked about the pigtail. Okay, flush, holes on the shaft all around the end of this, sprays all over the place, okay, and fills up the IVC and the aorta for you. You can open that to pass it around if you want. And I'm not going to open this because this is an inferior vena cava filter. We'll hold that. That's for another day. And here's the 7 French sheath here. Why don't you take that? Oh, sorry. Can you grab that? Sorry. What else? Balloons. Okay, again, everything you need to know is on the front of the balloon. So what this is going to say is it tells you the diameter of the balloon. This is 7 millimeters diameter, basically at the nominal pressure. Nominal pressure on this is probably 10, 12 atmospheres. It's 40 millimeters long. The way these are set up, this is always the flush port, okay? This is the balloon inflation port. Don't flush through the balloon inflation port or it blows up the balloon. And again, the way you handle these things, you just kind of fold them up. They always come with a balloon protector on them. So they always come like this. Don't put the balloon protector in through the sheath. It's not good because this is not radiopaque and you'll lose it. That's not good, okay? And if the nurse doesn't take this off for you and hands you, because often you're in a dark room. I mean, usually we're working with the lights down. That thing is gone. You ain't gonna find that because this is not radiopaque. And what happens is you won't be able to blow up the balloon. You're not gonna be sure why you don't break up the balloon. So you're gonna wanna take it out, and when you take it out, that's what's gonna happen. Okay, so these come off the balloon before you put them inside the patient. Now once you've done that, you see those 2 little white marks? So what is the length? Tip to hub or mark to mark? What's the 4 centimeters? Mark to mark, okay? So that's where you got the whatever you want to call it, the nose and the tail of the balloon, the shoulders of the balloon. The balloon itself is longer than 4 centimeters. The radiopaque markers, which is what you're going to see, are 4 centimeters in length. And the reason that's important is because if you have the back, some of these balloons are huge. I mean, you can get 14, 15 millimeter, even bigger balloons. And so the shoulders are big. And if the shoulder's going into a small artery and you blow it up, you can rupture the artery. So you've got to be aware of the shoulders that are on these balloons and how much it extends out above and beyond it. The tip of these is beautiful because it kind of fits to the, well, you want something that fits on the wire nicely. So you get the wire through an occlusion. Now you got to get the balloon to track over. Sometimes what happens is the balloon won't track over the wire. And then you may have to take a tiny little balloon, blow it up, make a little space for you to actually work. So then you're going to hook it up to an endoflator. What do you put in the endoflator? Contrast, full strength contrast. So as you pass these things around, most of these balloons are what are called semi-compliant balloons, that you get a little bit of incremental growth dependent upon what diameter you take them up to. So for example, you will get the 7 millimeter balloon will actually be 7.3 millimeters in diameter at 18 atmospheres. Every one of these has something like that attached to it. And then you have this endoflator. Never having used this particular endoflator. They're all basically the same, okay? This is filled with about 10 to 15% contrast, not full strength contrast. You never get the balloon up and down. It'll go up, take you forever to get the thing back down. But you need enough contrast in it so you can see the balloon. The balloon itself is not radiopaque. It's only the contrast that comes in it that is going to be radiopaque. And so these things all have a lock. So typically what happens is the nurse is going to draw up 3-4 cc's of dye, probably 10 cc's of saline. You don't want this full. You got to be able to generate positive and negative pressure with this thing. So you kind of only want it up to about 12 centimeters, so that when you deflate the balloon, you can hold this thing back, lock it in place, and it will suck down on the balloon. And if you look at this, you will see these bubbles coming back. So you don't need to go on fluoro to watch a balloon deflate. You go on fluoro to confirm the balloon is deflated, okay? You never pull a balloon out after it's been inflated without checking that it has deflated, because it doesn't always deflate. And that's your job to actually make sure that that happens. So typically they give you this. Who's got the balloon? Who's got the balloon? Where'd it go? Here it is, right here. So okay, which one's the guide wire channel? End one. Balloon inflation channel's on the side. Hold that. I don't know if someone will get air in here. It's not going to blow up very well. So we're going to unlock it. Typically we're going to come up to speed with pressure with this. That thing is going to pop up. We're going to be watching this to see what kind of pressure we're generating. And we're going to lock it in pressure and usually blow it up for 30, 40 seconds. Okay? And so you watch it when it's inflated, because what you want to see this balloon dumbbell. So if you've got a stenosis, it tends to dumbbell on either side of it, and then the middle comes up like this. And that usually confirms you're in the stenosis and you got it, accurate. Then you deflate it, and go ahead and deflate it. Just click this thing over, unlock, pull negative, relock it, and so now it's going to actually deflate, and the whole thing will come down. Then you go in fluoro. You just get used to doing this. It's just kind of, it's like walking. After a period of time, you just do this kind of stuff, automatically. But sometimes there's a stent on the outside of this balloon. There's two different kinds of stents. One is a self-expanding stent. You put in the catheter, you lever it, and it's made of nitinol. Nitinol stands for nickel titanium alloy. It was made by the US Navy, actually, and it's a metal that has thermal memory. So the way it's built by the manufacturers is the chemical process called annealing, and they set it to 6 millimeters by 4 centimeters. Then they cool it, and as soon as it's cooled, it is very malleable, and then you package it into a catheter. Then when you put it into the body at 37 degrees centigrade, it wants to go back to its original diameter. And so it is not delivered in a balloon, it's delivered in its own catheter. You deploy it, the whole thing will automatically reconfigure. But it has now enough hoop strength that if you're in a stenosis, you often have to come in and either pre-dilate it, tee it up for the stent, or you post-dilate it. Sometimes there are stents mounted on the outside of that balloon. They're made of stainless steel. They have a lot more hoop strength. There you got to worry a little bit about the stent being displaced when you actually put it in there. There's different techniques in terms of doing that. All right, maybe through the bag of tricks here. Oh, coils. Yeah, you don't need to know about coils. Another day. Yeah, give that back to these guys. It'll be forever before all this stuff gets back there. Any questions about this? Any questions in general? All right, tell you what, I'm just going to go ahead and do this. Linda was going to come up, but we'll just keep on rocking, knock this out. Okay. Fireball. This is the old PowerPoint presentation. So we talked about a little bit needles. So different kinds of needles. Typically use micropuncture needle. If you're on the venous side, it's okay to use an 18 gauge needle. Guide wires talked about, introducer sheaths, catheters, inflation devices, balloons, and I got most of this stuff covered. Okay. These are actually from a little book written by Peter Schneider. It's I can't remember what it's called actually, but it's all kind of pencil drawings, the basics, and an introduction to how to do endovascular procedures. And so most people are going to use the right femoral artery for access if you're going north. It's just a lot easier to stand on the right side of the patient, have the image intensifier set up the way it is, and have the monitor set right in front of you. Okay. So, where do you access a femoral artery? Okay, ignore this for a minute. Where should the puncture of the common femoral be? Over the femoral head. Okay, You can't see the femoral head. You can't feel the femoral head. Generally, you fluoro. So typically what we'll do is kind of localize the groin, put a hemostat where we think it is, bring in the image intensifier and fluoro and see where we are. You'd be shocked how far off you are sometimes. What does the inguinal ligament tell you about it? Nothing. You can't feel, you can't see the inguinal ligament. So, we used to criticize the cardiologists because they stuck above the inguinal ligament. It's because they knew what they were doing and we didn't at that point in time. Inguinal ligament does not help you. And so sometimes on ultrasound, you can see the femoral head. You can sometimes see that circular calcification behind it, which is fine. Then you're right on top of it. So you want to be over the femoral head, usually in the medial third of the femoral head, and you want to be above the bifurcation where it divides into the SFA and into the profunda. You can go retrograde or you can go antegrade. We'll show you some of the problems with going antegrade. This is what a retrograde stick should really look like. You're coming in about 45 degrees. There are two different techniques. There's a so-called double wall puncture technique and single wall puncture technique. Most people use a single wall. It used to be that used a needle that had two components. You went through and pulled back. You don't need to do that if you're using ultrasound. Just do an anterior wall puncture and do it under ultrasound guidance. And the bottom right-hand corner shows you where you should be sticking this thing. So double wall is through the back, pull back. Typically, once you get access to it, working. As soon as you get a flashback, usually drop the needle down so it's a little bit more angled, then you pass the wire. The wire should go, as I said yesterday, easily. Well, the first thing you're going to do. So we got the wire up there. It's in about 18 inches, but you don't have how it's in. There's no marks on that thing. It tells you how far you've got up there. What are you going to do next? Back row. Wire's in. Before you put the sheath in, what are you going to do? Fluoro, okay? Make sure your wire is going where you think it's going. It should be going that way. You will see them go that way. You will see them go up through a branch and be sticking out the iliac crest. Sometimes the patient will tell you they can feel it out there actually. So essentially, this is the way you're going to do it. You can infiltrate the local anesthetic all the way down under ultrasound guidance. Don't need to do any of this blindly at the moment, and then confirm and fluoro it. Talked a little bit about this stuff. Talked about this stuff. It's kind of, again, this is the old way of doing it. Our cardiologists still do it freehand. They don't use any ultrasound. It's good to know how to do it, but there's not really in a place like this any rationale for having to do that. You can't feel a vein. You can feel an artery if it's pulsatile. If it's not pulsatile, you can't even feel it. I mean, it's just basically doing it blind. If you're going to do it blind on the vein, you kind of put your fingers on the artery, so you get the artery is right underneath your finger, so you're not sticking it, and then drop down beside it. Usually you can hit the vein, put the head of the patient up, and this is just this kind of technique that we're talking about. This is where we thought we should stick it. We're not even close to where the femoral head should actually be. So skin landmarks are unreliable, particularly in obese patients. Always make a little skin neck. I mean, what happens is if you don't make a skin neck, you can get the wire in because it's going through the needle, but then the sheath doesn't track up, and that's when it backs out the dilator out of the sheath. So just get in the habit of taking, using an 11 blade is what we use now, is just make a little incision, insert the needle about 45 degrees. Ignore that. All these entry needles tell you how long the entry needles are, tell you what gauge they are, and they'll tell you what guide wires they're going to accept. An 035 wire will not go through a micropuncture needle, okay? The micropuncture needles all have an 018 or an 014 wire, so there is an extra step in doing that. Small wire in, dilator goes over that, there's an inner cannula comes out of the dilator, then your 035 wire goes in, basically on the back of this. I don't know if anybody, we don't use these are these two-piece needles. This is typically, the way you'll handle it. And we use either an 18 gauge or a micropuncture needle. Talked about this. Sometimes if you can't get the wire in, you can actually inject through these needles. You can actually do a little arteriogram so you get some idea of what the anatomy is and why you're having trouble getting access to it. This is particularly valuable if you're trying to do what's called an antegrade puncture. Left iliac may be occluded, aorta may be diseased. You may not be able to get access to the right side other than sticking antegrade. Now that's tough because you got a patient with a big belly. It's damn near impossible actually. But you can't stick it here. You got to stick it higher than you would normally because you need to be able to get a catheter in here and direct it. When you stick it antegrade, the wire almost always goes down the profunda. So you need enough running room to get a device inside the common femoral artery so that you can steer the wire over to the SFA. And once you get in there, it's a little bit easier. brachial approach. Okay, you cut down the brachial artery, yes, a much higher complication rate coming through the brachial artery. And you can stick the median nerve. You can see the median nerve in ultrasound, actually. Try and stay away from it. But we heard the other day about these little hematomas that you can get and can be a problem. So if you go back and see somebody and they've got paresthesia or pain in the median nerve distribution, you probably need to explore this. So it's pretty low threshold for cutting down and evacuating any hematoma that's around there. That's the reason most people go through the groin. Vessel dilators, we haven't really talked about. So the thing that's in the inside of that sheath is a dilator. Every now and again, you're not going to be able to get these in. And so it's easy if the groin's not been operated on before. If the groin's been operated and it's full of scar, nothing's going to go through it very easily. So you need to get a stiff wire inside. Then you can, there's a pack of dilators that will go from 5 French to 6 French to 7. You have to serially dilate up that track before you can actually even get a sheath to go on in there. This is the big one. This is a 9 French sheath. Okay, J-wire. J-wire comes with these, but you can also get these long wires which also have a J-tip in them. J-wires are a good way to cross a stent, okay? So if you've got a pre-existing stent that's in there, and you take one of these glide wires up there, it can go through the stent. And then what? That's fine. It's going to go right through the stent, right through the interstices of the stent, and then keep on trucking. And then you bring your catheter up there, and maybe you're working above the stent, and you're not looking at the stent anymore. And that damn catheter, you won't go. And you push on it, and then it goes. And if you're lucky, it doesn't take the stent along with it. If you're unlucky, it moves the stent. And if you're really unlucky, your catheter goes through the stent, and you can't get the damn catheter back out again because it gets jailed inside the stent as you try to take it back out. So if you're crossing stents, sometimes the catheter itself forms the wire itself forms a loop. That's a really safe way to cross a stent. Or you use a J-wire, because the J-wire is not going to go through the stent. It will find the inside of that for you. Sometimes we use these when we're doing open. If we're doing endarterectomy and an iliac stent, we work through these things basically open at the same time. They're color-coded, talked about. It's just the way that you do this is doing an exchange. Needles in there. Let's say we're looking at the front of the aorta. Somebody's here. The communication that takes place between you and the assistant is who's got the wire, okay? So when I am taking a catheter out and you're here and the wire, your job is to make sure that wire is not being pulled out at the same time as I'm pulling that catheter. And my job is to tell you as soon as the wire is free that I've got the wire. And that means you can be pretty vigorous in taking that catheter out. When you're putting, so likewise, when let's say we're now putting a balloon in it and you're loading the balloon on the back end of this thing, your job is to tell me you've got the wire. Because then I'm going to take the balloon and put it fairly rapidly move it inside. If you don't have the wire and I push the device in, the wire goes in with the device. And I then push the balloon in, and I look at you and you look at me and we look at the end of the catheter and there ain't any wire coming out of that. Now again, if you're lucky, it's in the catheter outside the patient. If you're unlucky, now you lost the wire inside the patient. Now you get to talk to the federal government, because that is nationally reportable by every hospital in the country as a lost guide wire. So you're in for some misery for a period of time while you start explaining how that managed to happen. Then there'll be about 45 new regulations in the hospital, all of which will have your name on it, and all your fellow physicians will love you, because now there's another 10 checklists that we actually got to go through. So don't lose the wires, okay? We've talked about this. Again, the way it's loaded, flush, take this out, put it in the back side of it. That's what it looks like when you're actually going to introduce it into the patient. So straighten the end of this, the wire. That's how you pull back a little bit, jam this through the valve, push the wire on through it. That's how you get these things going through it. Now we've almost completely gone over to using what are called bright tip sheaths. They have a little radiopaque marker on the end of them, and the reason you want to do that is because you can't see these sheaths when they're inside the patient. And if, for example, you're working in an iliac artery and you're going to put a stent in it, and you spend all this time, it's nicely positioned, you blow it up, one end of the stent goes like this, and the other end of the stent doesn't deploy. It's because it's in the sheath. And so that really is crazy that they don't all have radiopaque markers on the end of it, because if you've got this nice bright metal thing, then you'll see that it's halfway up the stent, and you'll back this down so that you can go ahead and deploy the stent. All right, so we're going through this. Sheaths come in different lengths. And this is probably a 35 centimeter sheath. These are designed for treating, for example, the aortic bifurcation. And if you're going to put balloon expandable stents in, let's say we're going to do kissing stents, come up from both sides. These go up into the aorta, okay? They are across the bifurcation. You bring the stents up inside the sheaths, you position the stents, then you pull the sheaths back to expose the stents. And the reason you do it that way is this is the safest way of doing this, so you don't lose the stent off the outside of the balloon when you're coming through a diseased artery. It's going up inside the sheath, and then you pull the sheath back, okay? The other reason that these long sheaths are valuable, if something happens to the stent, you lose the stent, you rupture the balloon, then the stent is very helpful in trying to recover from that situation, because you can give you a lot of stability. Every now and again is that you will find that the balloon ruptures, and so when you deflate a balloon, these balloons are all designed to deflate in a certain way. Some of them have 3 or 4 wings on them. The manufacturers designed them to refold. You spin them counterclockwise and it refolds. If a balloon busts, it doesn't deflate, okay? You don't get this deflation, so it kind of hangs up in there and can get caught in a stent. And so what is very useful is to be able to take, imagine at the top end of this is a half deflated balloon. The wire should be coming out here, and the shaft of the balloon, you can advance this up over this balloon. It collapses the balloon down, and so you're pulling back on the balloon shaft and you're advancing this at the same time, and it will basically help you retrieve the balloon. So it's real helpful to have that. It can also be used to stabilize the stent so you don't move the thing. Scar groins, I think we've talked about. 5 French catheter, we'll go through a 5 French sheath. Again, this is just simple techniques for replacing the sheath. The wire is up there, taking this out, put your finger on the hole, somebody's controlling the groin. And you take a 5 or 6 French sheath out till you make it bigger, it's going to be bleeding subcutaneously, so somebody's got to control the groin. Essentially what you're going to do is put pressure there, and you're going to use your other fingers to grab the wire, and you're going to tell your assistant that I've got the wire. My job is to control that wire, his job is to put the next device in there. And then he's going to deliver this up to you, he's got the wire, sheath is going to be going in there. And this is kind of the setup if you're going to do in bilateral iliac stents, for example. Different approaches. If you're going to do the left leg, usually coming in the right side. Okay, so you're going to go up and over with the bifurcation with a sheath. There's different techniques you can actually use to place this and to deploy this. Linda, do you want to talk?
Sure.
I'm just talking. I've gone through some of the devices. We're just talking about techniques. These are Peter Schneider's slides. I was talking about going up and over and different ways of doing this.
Okay, so this is just a simple picture of it going up and over. So usually this is our traditional way, right? Doing an angiogram. You come from the contralateral groin, put a wire across, shoot for an iliac angiogram, and then put the wire over, and then put a up and over sheet. Do y'all know any other ways of accessing a lesion and fixing it? Retrograde, right. So what's this called? Retrograde. And then just talk about sheaths.
They know a little bit about sheaths. Haven't really talked about sizing the sheath for the procedure that we're doing. These are just generalizations, Linda.
Okay, so you want to try to be cost effective, right? And that's the big thing I learned at Ashland is that if you go in private practice, they will look at how much you spend in the OR and how much you bill for. So you want to use as minimal equipment as possible. So in terms of sizing your access sheet, you want to think about what your lesions are and what's the biggest lesion you're going to treat, right? So there's iliac, these are some examples, iliac, SFA, and then there's tibials, right? How many, we won't treat comment on this, but iliac would be probably your largest. And so usually you can use a 7 French because those would usually be stents that are 8, 9, 10, 11. And then SFA is usually 6. And if you do tibial work, you would pick a 5 because you don't need anything bigger than that usually. Open. That's about it. Okay, so then y'all we talked about antegrade.
Yeah, I think I've covered most of the antegrade access, actually. Yeah. badness. Fall on the wire. This is kind of what happens. See, the wire's going down the profunda, and I've stuck it too low. So you can't kind of get out of that. See, so it's what I was saying earlier is the access point is right on top of the profunda. You have no control over the wire. So the wire, remember the needle's got to go in there 2 or 3 millimeters. So you're right on top of this. You can angle the needle, but that's all you can do to try and control this. So this is not good technique, and then trying to do it this way. Yeah, it's probably not fair me sticking you in the middle of this thing. There's take that one from scratch and talk about how you do any grade. Yeah.
So what's the one problem that Dr. Lumsden said about integrate?
Yeah.
And not having enough purchase, right? So like if you're trying to treat a lesion here, think about how that's like the only length that you will have to fix it. So you want it to stick as high as you can, but not in your ligament, right? Because what will happen? Problem with your access, please, right? And so that's why we use ultrasound, not radiology. So then doing this, and then this actually also works for if you're working on a bypass. Great radial force and precise deployment. So short little lesions that you need, to be pretty precise on, and osteo lesions that are really calcified. So that's good for balloon expandable. Balloon expandable, you usually do not upsize, right? So like if it's a 7, whatever, then you pick a 7. But self-expanding, you usually upsize 1 to 2. Okay. So then there are covered stents. So what is the covered balloon expandable stent? ICAS. So what's the covered self-expanding stent? Right. Gore is about to come out with the balloon expandable covered stent. Both much more expensive. Their whole thought process is to decrease intimal hyperplasia. With Viabonds, you do not want to oversize that much because they will kind of, with the fabric and everything, they'll kind of bunch up. So that's sizing. What else?
You mean oversize 1 to 2?
1 to 2. So say a vessel, say we're doing the SFA, right? Yeah. So the SFA is 5 millimeters. If I use a self-expanding stent, I would upsize to a 6 or a 7. But if I'm using a covered stent, I don't want to upsize too much because of that fabric. That'll kind of, I don't know what the word is, but crinkle. Yeah, crinkle. Thank you. And then balloon expandable, you don't have to upsize. But with balloon expandable, you can, if you need to, like say you put it in, you're like, oh, I need, more opposition, you can put a bigger balloon and sort of stretch it out.
Yeah, this is just kind of showing how you can puff in. These are actually threshold complications. Maybe you want to talk about, forget the percentages, the complications that we sometimes see.
Yes. The percentages are just...
This actually comes from an SI, Society of Interventional Radiology. If you're setting up a practice, these are kind of threshold complications that are deemed to be acceptable. So this is kind of an average of what is out there.